Welcome to the Ortho Joke Podcast, a joint production of the Journal of Bone and Joint Surgery and Ortho Evidence. Join hosts Mohit Bhandari and Marc Swankowski as they discuss current topics and publications in the world of orthopedics and beyond.
Well, good morning, Mo.
Morning.
And it's a real early morning where I am. I'm all the way on the West Coast, so it's still dark out here in Seattle, and the coffee shops haven't opened, but I'm sure you're well prepared as always.
I always have something with me. Yes, this is a warm cup of coffee. It's actually Tim Hortons coffee, but I've put it into kind of, class it up a bit, just a little bit.
Yeah, that's great. I hope to be into something like that very shortly when they open. But, it's fall. There's lots of sports activity going on. A dramatic end to the Ryder Cup in New York City with notoriously bad fan behavior, which is unfortunate for the U.S. But the Euros won and were dramatically ahead, but it came down to the last few matches. So that was good. And then, I've got several football teams that I've followed, and my USC Trojans lost their first game, and the Vikings lost again. So there's a little bit of a downer here in terms of the football part of my life. But there's always orthopedics and academics.
Yes.
And there's always science.
Can uplift you,
right?
I can always
moving
uplift
the
you.
field forward, and all these things that really change your attitude at 6 o'clock in the morning. And this is an episode where one of us picks an article that we've published recently and decided to highlight. And I have my choice, which is a manuscript about patient-reported outcome measures, which has been a big part of my academic career, having developed and validated several PROM instruments. And this is a very interesting article that comes out of Beijing. It's kind of a new concept in this. It's the smallest worthwhile effect as a promising alternative to the MCID in estimating PROMs for adult idiopathic scoliosis. And this is a jargon that may be over the heads of several members of our listening audience. But so this smallest worthwhile effect enables patients to evaluate the expected value of a treatment by weighing its benefits, risks, and costs. And it is proposed as an alternative to the MCID, which is a PROM measure, minimal clinically important difference. And their study was attempting to determine the SWE estimates and MCID thresholds in patients undergoing surgery for adult idiopathic scoliosis, which are huge surgeries and involve a fair amount of risk in both in postoperative complications and risks of poor outcomes, et cetera. And so they took a cohort of patients and examined them at 2 years postoperatively. And they had 119 participants, mean age of 26 plus or minus 7, and they measured the SWE 50 estimates and then compared them to the MCID thresholds for an instrument that was developed through the Scoliosis Research Society. It's called the SRS-22 questionnaire. And they did the statistical analysis, which I'm going to ask you to comment on. And they concluded that this SWE can serve as an effective alternative to the MCID for interpreting PROMs at a minimum of 2 years. And maybe I'll start with, can you clarify what the MCID is and how it's calculated?
Yeah, and I might even take it back if I could, Marc. So obviously, I think I met you, or I'd heard of you at the time of your development of the SMFA and the MFA, the Musculoskeletal Functional Assessment Tool. And this was when Gordon Guyatt, back in the early 1990s, was really promoting at McMaster evidence-based medicine. In fact, he coined that term, you recall, in 1989, 1990.
Yeah.
So back then, it was always, clinically important benefit, which was, if you think about it from the point of view of physicians and surgeons, it would have been, okay, I believe I understand the pathophysiology. Therefore, I believe, as the surgeon treating you, this is the important measure. 10 years later, Gordon wrote a paper, and I remember very specifically, he had said, we've got to move away from clinically important outcomes to patient important outcomes, which gets back to this whole idea of MCID and everything else that follows, which was, it was a paper and something was called the ACP Journal Club. American College of Physicians had a journal club, and they published it, I think, 20 years ago or so. And bottom line is the argument that we have to really ultimately look at what is important to our patients and ultimately let them make the decisions. And so they came up with this idea of minimal important difference, minimal clinically important difference, and a host of, permutations there often. But the principle was when you have a continuous score system, so a score that as a number rather than, infection, yes or no, it's a scale. How do you know, like, when a scale is important? How do you know if 1 point versus 10 points versus 20 points means it's something important? So they developed these statistical techniques, and you can imagine, right? One way was, as Gordon talks about now, it's called an anchor. You say you compare it to something. So in the simplest point of view, you would, over a period of time, give people a scale, and they'd get a score, 20 points, 30 points, 40 points, whatever it is, as they were improving. But then they would also be asked independently at that time, how do you feel? Do you feel better? Do you feel not so much better? And then, so they were trying to find an anchor that was something that was patient driven to say, well, the minute the patient says they feel better, what was the actual difference? Like that the scale was picking up when they suddenly noticed something is better or worse. So it was this anchor-based method that became the methodology and sort of the gold standard, which is you got to find something you can anchor against. In this paper, that's exactly what they did. I think in fact they used the term, we used an anchor. But as you can imagine, as science evolves, there are other methods where they said, well, let's say we don't have an anchor, but we're just going to use the data we have on this tool, on this scale, with all the, and the curves that develop, the histogram, the, sort of the curve, the normal curve, whatever that curve is. And we're going to use something called a distribution or a statistical method. And we're going to come up with standard errors, and we're going to try to figure out what we think based on this. And Jeff Norman and a bunch of other scientists at McMaster, a number of them did it, came up with a whole bunch of theories. But one of them was, kind of a minimal important difference can be roughly half of the standard deviation, of the actual scale you're using. It was a rough estimate, and they seemed to think it was pretty robust. So now it's been this discussion around, well, which is better? I will tell you that at least the thinking at the university that I'm at and with some of the individuals who are really prominent in this field, they believe anchor-based methods remain the standard. And as I understand, something that moves to like this idea of the smallest, with the smallest worthwhile difference, smallest worthwhile effect, really is an anchor-based tool that looks at patient-important anchors. But still, what it does is it adds one other element, which is the costs and the benefit. I'm sorry, so the benefits and the risks. So it's actually doing the modeling, which it says, MCID says, here's a scale, here's the minimal important difference we think that works. That would be, that would be clinically important, let's say, or patient important. And I believe what we're talking about in this paper is they've actually modeled out the smallest, worthwhile difference or smallest worthwhile effect in consideration of both the benefits and the harms. So you can kind of see how that would actually play out. Now, you can get into the statistics of people arguing about, was it done accurately? Was it enough sample size? But in principle, the idea is a good one. And I think in principle, that's what we do in real life, right? You weigh out the benefits and the harms. You don't just say, okay, well, here's all the good that can happen. Oh, by the way, you can have a, horrible event. And that patients have to weigh both of those out. So I think that is sort of an appraisee, how I see how all this all fits together.
Yeah, you're making a very important point about the sample size in this particular investigation. And so often in the journal, we publish manuscripts that are on the early part of the curve in introducing concepts that maybe aren't perfectly done in this case because of sample size and a single diagnosis, et cetera. But it's to put it out to the orthopedic academic community as a new concept for them to consider further investigation, the use of this tool. I have had many times when manuscripts are presented or published on the MCID, and oftentimes the reader or the listener will conclude, well, it didn't meet the MCID. You've outlined how it's calculated, and it's always important to understand that the MCID is different for different patients. And what we're talking about in the academic or scholarly environment is groups of patients where the MCID is established. But if you took the MCID for a professional athlete with Achilles tendinopathy, that would be very different than the MCID for a 60-year-old sedentary individual. And that's important for clinicians to understand that it's a calculation of groups, not for individual patients. So that's something I always try to point out when people are concluding that an intervention is not worthwhile because it didn't meet the overall MCID for that tool.
Yeah, and that's a great point too, Mark, because like what you're saying is on average, when looking at
Exactly.
all different folks and all different experiences, it doesn't seem to have in effect, if in fact it didn't, right? Let's just say. However, exactly to your point, how do you interpret an average? That's the problem always when you're trying to make these, judgments. And what they've been doing now in some of them, and Jason Bussa, who we've had on
Yep.
a few times, has
Yep.
been doing some analyses where what they'll do is they'll break the MCID into a proportion. So what they'll do is they'll say, okay, there's a study that has an average MCID, an average of effect that was below what would be considered the average minimal clinically important difference threshold. But then they'll look at every person and they'll say, well, actually, as it turns out, 30% of the patients in this study actually exceeded the MCID. And that's exactly what you're getting at. And it may turn out that these 30% were an important subgroup of individuals that you don't want to just throw the treatment out and say it doesn't have an effect. It has a varying effect, but the average effect may be misleading sometimes. And so I think breaking it down to the proportion of individuals. So, what they'll do is they'll take study patient 1 to 119, let's say was a study, and they'd say, did this patient exceed it or not? Yes or no? And then they can look at a proportion there as well and create a confidence interval around that, which I think is another way to look at information and data. And if you see differences, then you can start exploring why.
Yeah. Yeah. Well, let me conclude by pointing out to the audience that I've passed on the hot seat to you in terms of the person who signs off on what we actually publish in the journal. And these decisions are difficult because, the vast majority of readers of the journal don't really get a whole lot of joy out of these statistical type analytic papers, but yet they have an important role, which is why we publish it. And it's a very difficult thing to decide what percentage of how we make decisions of what we're going to publish are
Yeah.
in this really high scientific statistical realm. And can you just, I mean, you've been at this over a year
Yeah.
now, and you've sensed the struggles and how to balance things out. Where are
I
you
think
with
that,
your thinking on this?
yeah, there's two things that are truisms, right? If JBJS accepts my paper, boy, oh boy, they got it right. They got it right. Of course, they did accept my paper, but man, they got it wrong. They got it so wrong. So, and I do I write, and I continue to write, and I have the exact same experiences that everyone does. So, we're all biased, and we all think our work is worthy of praise and certainly getting disseminated. And our job is to do everything we possibly can to take the work that is worthy and disseminate as widely as we can. But there's always tough decisions to be made. And I think learning a lot from you too, Marc, is, you had a very strong team of people around you that were, collaborating in helping, balance sort of all those considerations. The statistical side is really important, and having a strong methods appreciation. And I think we're seeing just overall the quality of methods understanding in our field is just, go back to 1990 and now, right? And it's just completely different.
Huge,
And
huge
so
progress.
just so much more knowledge, right? And now what we're getting into is really, in many cases, complex modeling and modeling issues. And that is a different level up, and there's a different level of expertise. And that just, again, talks about how far we've advanced. So I look at the more scrutiny we're putting on the analytics is because the analytics are certainly now getting much more complex and much more, and their results have huge important impact potentially, right? So it's really just building a team and continuing to scratch your head when you think there's, when there's important issues that you want to make sure you get out, but you also know you want to get them out in a way that allows the journal to communicate its message, locally and abroad. And that's what we're trying to do. And it's certainly been a huge, huge learning curve for me on a personal note, but I know you're there. So, you're just a call away.
Yeah, well, yeah, I'd also point out that you brought on additional expertise into your leadership group in methodology and statistics, and expanded that group that really is built on the outstanding work that Jeff Katz and Eleanor Lucina and et cetera, Andrew Schoenfeld, who really done great things, Stephen Lyman, et cetera. And it's really, really important that we have that kind of expertise that are figuring in to the decisions made at the journal. And my end comment is just to remind the audience that we practice double-blind review. And so we do everything we can to try to remove bias out of the initial review process before it moves to the next level. And finally, I'll point out that my personal last 3 submissions to the journal were rejected. So, but I'm not angry about it. But you'll be hearing from me if the 4th one gets rejected.
You have my email. Everyone has my email. They can find me. And trust me, I will tell you, Marc, as I understand that you told me this, because many people do find you. I get found a lot. So I'm happy to have those discussions, obviously.
Yeah. Well, that's great. And you're off to a great start, and congratulations. And I know the journal is going upward and onward and into new horizons. And having just experienced the annual editorial meeting, we're all very excited about where we're headed as an organization. So congratulations to you, and enjoy the hot seat.
It's a hot seat, but maybe the last cliche here is we're standing on the shoulder of giants. So there you go.
Okay. Well, cheers. Have a great day, Mo.
You too. Have a great day.
Bye.